Let me tell you a little bit about myself. Obviously, my name is Mark Rosenberg. I'm board certified in emergency medicine, although I haven't done a shift in the emergency department in probably about 3 years. I've been assistant director of many emergency departments, but I've been involved in a lot of research for many years as well. I wrote a book in Poisons and Overdoses in 1991, 18 years ago, a book for physicians in handling toxins and overdoses. So I was very much into research. Very typical academic guy, and certainly followed the lead. I was a good soldier, and I really learned and taught. I did a lot of teaching. I learned everything very well. But I started really branching out into research. As a matter of fact, before I started medical school, I was considering going into research. I was kind of torn between research and clinical work, and I ended up doing both. But what a 180-degree turnaround I've done in my clinical work. I began researching obesity about 9 years ago, and I actually developed a drug that I'm hoping will be the holy grail for weight loss. And so I just started a pharmaceutical company. About 3.5 years ago, my mom, I had the misfortune of diagnosing my mom with metastatic lung cancer. She smoked about 2 packs a day, and she'd already had breast cancer that was cured with mastectomy, and she refused chemotherapy. She had a bypass, continued to smoke, and of course she came to me one day with pleuritic chest pain. And CAT scan at the time showed mets from the lung to the liver, the spleen, the adrenal glands, bilateral adrenal glands, and left hip. And so she certainly didn't want chemotherapy, and I didn't blame her, but that's when I shifted gears on research to cancer. And I feel like, especially with the internet, the availability for research is unbelievable now. I mean, I don't know much about cars, but if you gave me a year and all the time I had, I think I can know as much about cars as anybody in the world. And that's the way I approached it with cancer. It doesn't make me special at all. Anybody can do it if you're willing to put in the time. So I began researching cancer, and it became an obsession with me. And I was amazed with the amount of material out there, and amazed with the data of what we're typically using, chemotherapy, surgery, radiation, and how we were ignoring so many other things. So with one hand tied behind my back, and I say that because my mom decided what I could do and when I could do it, I began treating her. And I started with just using high-dose vitamin C and adding many other things. And I discovered a lot. I went up to 200 grams of vitamin C in an infusion with her. Incredible anti-inflammatory properties. I mean, my mom had a lesion eating away at her hip. And before we did a 200-gram drip, she couldn't walk. Excruciating pain. And of course, following a 200-gram drip after she finished vomiting her guts up, she walked without a limp. So I saw some amazing things. Now, I also know that vitamin C did not cure cancer. But I certainly saw an incredible anti-inflammatory effect, even though at those doses, vitamin C was pro-oxidative as opposed to antioxidant. So let me start out by telling you that any physician is capable of treating cancer. And when I say treating cancer, I'm actually talking more about the higher grade cancers than the lower, or higher stage cancers rather than the lower stage cancers. And I say that because many or most stage 1 and stage 2 cancers can be treated surgically. And believe it or not, adjunctive chemotherapy or neoadjunctive chemotherapy and or radiation therapy is a good thing for many stage 1 and stage 2, and that takes care of it. But for stage 4 and many stage 3s, we've come nowhere. Chemotherapy, as I'll show you, I think is not only ineffective, but may actually potentiate the aggressiveness of many cancers. And it may actually temporarily slow down or improve progression-free survival. And let me explain what progression-free survival is for people who don't understand or who don't know what it is. If you improve progression-free survival, that means that you are extending the time through which there's no progression of cancer. But it doesn't mean that it improves overall survival. So, for example, chemotherapy may make you happy because you look at the CAT scan and the cancer's going away or it's not progressing. But then 6 months later, it flies and it kills you in a month. And so that's what we're seeing a lot with chemotherapy. And there are many of us who think that chemotherapy potentiates the resistance of cancer stem cells, which is probably responsible for the proliferation and metastases of cancer. So I have now devoted my life to cancer research, and this is definitely something that any physician can do. I'm not an oncologist. I like to think that I can go to bat with any oncologist, but I consider myself a cancer scientist. I have a study going on at Wake Forest University. I go back and forth to Central and South America because I don't have the FDA on my back there, and I can do things without worrying about the FDA. In most countries, they've passed a law, including in the European Union. They passed this law about 9 months ago that says if the patient has a terminal disease, and by definition, if it's terminal, we have nothing to cure it, you and your physician have a right to use whatever you want. That law does not exist in the United States. So it's very, very difficult to do what we need to do here. But I'll get into so much of what I'm doing inside and outside this country. And my goal is to get as many people as I can, as many physicians as I can, to help practice integrative cancer therapy. That's the term that I'm using, and that's the bottom line is using everything that works. Okay, let me begin and start off with the definition. According to the American Cancer Society, cancer is a group of diseases characterized by uncontrolled growth and spread of abnormal cells. I disagree with that basic fundamental concept. Okay, well, in the past 40 years, we have minimally extended survival for most solid tumors. If you look at the data, I mean, we can do incredible things. I mean, look what we've done technologically speaking with our space travel, but we have really done a poor job in dealing with metastatic solid tumors, and we're not much better now than we were 40 years ago. Now, it's not uncommon for new drugs to reveal spectacular results by curing cancer in mice. And that's very exciting because, you know, cancer in mice is a big problem in this country, and I'm glad we're able to handle that. But we're not doing much for humans. So you have to ask this. If we're curing all these cancers in mice, but it doesn't apply to humans, are our models through which we research cancer in the laboratory valid? And I think you know the answer. So how do we typically research cancer in mice? We do human tumor xenografts. That's the most common. It's real cheap. You take cell lines of cancer from people whose cells we've taken a long time ago. It's sitting in a culture medium and mutating. So how closely does the cancer we're studying now resemble the original cancer? Maybe not very closely. And then we just inject it subcutaneously in the mouse. And then we hope it grows. And then if we give a drug and that tumor shrinks, we say, hey, this seems to be effective against cancer.